So I get to introduce next Dr. Kate Sigford. Kate went to med school at UC Davis, and then they did their residency in physical medicine and rehab at Stanford a few years before Dr. Mitsu did. Dang it, I keep saying her. And then they did their, I don't know why I'm saying Yumi's name wrong all of a sudden today. It's the nerves, I'm sorry. And then they did their Peds Rehab Fellowship at Gillette Children's Hospital in Minnesota. Okay?
Thank you. I was telling Dr. No during the break that as her talk got into the first slide about botulinum toxin, I worried a little bit that I'd be repetitive, but she very nicely left me some things to talk about here. So I will talk about not just upper and lower limb indications for botulinum toxin use, but more broadly, almost anything you can use it for in pediatrics. Most of the musculoskeletal, but we will diverge a little bit from that. First, though, to start out, I have no financial disclosures, but I will talk about off-label use of medications during the course of this talk. A little bit first about botulinum toxin itself. It is produced by the Clostridium botulinum bacteria, and there are 8 serotypes. The human nervous system isn't susceptible to D, and in our medical usage, we pretty much just use type A and type B. The mechanism of action comes back to the neuromuscular junction. You may remember that the nerve does not actually touch the muscle. Rather, vesicles filled with acetylcholine have to dump out the acetylcholine to activate the muscle. What the botulinum toxin then does is it breaks one of these SNAP protein, or one of these snare proteins that allow the vesicle to dock and keeps the acetylcholine-containing vesicle from docking with the cell membrane, thereby keeping it from activating the muscle. This is both how it works and why it's temporary, because the nerve is smart enough to figure out over the course of time that something has gone wrong, I'd better fix myself. And this is where we get the temporary duration of action of the Botox. Onset and duration of action, speaking of which, we go by the rule of 3. It's not, which is that generally you don't see effect at the time of injection, though sometimes patients or their parents will say that as soon as the medicine went in, it helped. That's not terribly common, and it's also not alarming if it doesn't happen. You can usually start seeing an effect of the toxin by about the 3rd day after injection, and it may continue to increase in effect as it affects the nerves through week 3. So it may keep getting stronger and stronger. Average duration of action is about 3 months. It could go more than that. It could go less than that. And for most of the formulations commercially available in the United States, the FDA-approved dosing interval is 3 months, so no re-injection sooner than 3 months. There are a few exceptions to that, but they're all on the longer side than the shorter. Commercially available in the United States are 4 formulations right now, of which Botox is the original and probably the best known. That's onabotulinum toxin A, and much like Kleenex has come to mean anything you want to blow your nose on, Botox has pretty much come to mean any sort of botulinum toxin, which sometimes drives me a little bit crazy when I'm talking about doing a Dysport injection on a patient and somebody else comes and says, "Oh, are you doing your Botox injections?" "No, I want Dysport today. Don't talk about that because one of these days we're going to screw up and bring the wrong medicine." So they're the onabotulinum toxin A, abobotulinum toxin A, incobotulinum toxin A, and rimibotulinum toxin B. That's the only B that's available in the United States right now, and seems in many of the studies in pediatrics to have a slightly higher incidence of adverse effects than the A's. There was a real nice review article in the Journal of the American Academy of Physical Medicine and Rehabilitation. I believe it was published in the September edition, that talked about all the pediatric indications of botulinum toxin, and which made updating this talk very easy. Units. What are we measuring this in? All the formulations are measured in mouse units. Usually people just say units rather than mouse units. And 1 unit is the amount of toxin that kills 50% of a group of mice if you give 1 unit to each mouse. Why do I say this? when it's morbid and may not mean a whole lot. The reason is because they work differently. 1 unit is a different amount for every formulation. 1 unit of Botox is not the same as 1 unit of Dysport, is not the same as 1 unit of MyoBlock. So you cannot convert interchangeably. You have to know what the dosing recommendations for the toxin you're going to use are, or what various folks who have done a lot of work with the different formulations have come up with as presumed approximate equivalent estimates. The next couple slides are going to be about adverse effects, and we're going to get the serious things out of the way first with the black box warning that is on all botulinum toxin products. This one specific is to onabotulinum toxin A. They're all very similar. It warns that there may be spread of effect from the area of injection to produce symptoms consistent with botulism or toxin effects anywhere in the body. That is, in the muscle you injected in on purpose, in the muscle next door, or in a muscle anywhere else in the body. This has led to serious adverse effects, very, very rarely, but it has led to very serious adverse effects with enough dysphagia that people needed feeding tubes while the medicine was in effect, or affected their diaphragm enough that they needed respiratory support. Regardless of where it's injected. Higher risk, of course, if you're closer to one of those muscles, but regardless of where it's injected. Some of the studies have suggested that our GM-FCS levels 4 and 5 patients are at higher risk of these serious adverse consequences, but that hasn't been consistent. Other adverse effects include injection pain and bruising. I'm not actually entirely sure why some of the studies listed injection pain as an adverse effect, and injection hurts. This is, so some of the studies have much higher rates of adverse effects than others, depending on whether they counted injection pain and bruising, those sorts of things that are going to happen when you give a shot. The other one that is somewhat common is a post-injection soreness, which I've had described to me from patients who's experienced it as feeling like after you get your flu shot. So it's not great, but it's not terrible, except for one person who got it a little worse than everybody else and said, no, it's like a tetanus shot. It's worse than a flu shot. Other issues can be muscle weakness. Now that's, again, is it an adverse effect or is it the effect of the toxin? This is what we're trying to do with our botulinum toxin. So I guess it depends on in what quantity and in what muscle. Is it the one we're treating or the one we're not treating, or did it go too far? As I mentioned before, dysphagia, breathing problems, pneumonia. And then last, interestingly, there is an incidence of fever and flu-like symptoms after injections of botulinum toxin, which is postulated maybe to be a result of the immune system reacting to the toxin. This certainly was fairly likely in some of the early onabotulinum toxin A formulations where there was a fair amount of extraneous protein. They're all much more pure now. And so it's a little bit more puzzling, especially since you don't see a dose-dependent effect in the placebo-controlled studies. All of that out of the way, you're probably wondering why we would ever want to use it anyway. having just told you everything that can possibly go wrong. Nevertheless, really for the most part is very well tolerated with minimal adverse effects unless you're going to count injection pain. So what do we use it for? As Dr. No alluded to earlier, we use it for upper and lower extremity spasticity or any hypertonia, in fact, for congenital muscular torticollis, for cervical dystonia, for birth brachial plexus palsy, and here's where we leave the musculoskeletal system, sialorrhea or drooling, and emerging use in pediatric for migraine. It's approved in adult for migraine, but looking like it probably works for kids too. Here is, in graphic format, the different formulations and what they're approved for. And in there, too, we get a couple other uses of botulinum toxin which aren't going to come up today, like primary axillary hyperhidrosis, and actually you can do it palms and soles, too, and detrusor overactivity. So first, we'll talk about use in spasticity. To review, when do we consider tone management? We don't necessarily need to treat all tone, and we don't necessarily want to treat all tone. Question is, what is that tone doing? Is it interfering with some part of life? Is it causing trouble with function? Is it causing trouble with positioning? Is it causing trouble with cares? Is it causing trouble with comfort? And sometimes you have to pry a little bit into this because the parents have gotten so used to taking care of their kid that, oh no, it's really easy to change their diaper. And then you watch them do it and they're prying the legs apart and sticking themselves between. And so I often say, is it easy for you or would it be easy for anybody? Oh, I guess we're just used to it. Probably nobody else could. What can we hope to do in terms of tone management with our botulinum toxin? First, decrease spasticity, decrease dystonia. We can make it easier to stretch because those muscles aren't pulling back so hard. We can reduce pain because these spastic muscles can be painful. And we may be able to improve function. But most of the time, the botulinum toxin injections by themselves will not improve function. You have to have a plan after that that usually will involve your physical therapists or your occupational therapists to capitalize on the different balance of muscles to help learn how to reuse things. Like, for instance, we have someone who's had wrist and finger flexion contractures. I can loosen those up. But then the occupational therapist is key. What do I do with this hand now that I can use it? I've loosened up the gastroc enough that your toes aren't pointing straight down. You can try to walk heel toe, but the physical therapist is key in actually working on that motor pattern. What can't we do? We can't lengthen contracted muscles. We can only get rid of excess tone. If the muscle itself has a contracture, we will not change that with botulinum toxin. We may assist with an aggressive stretching program and brace and stretching brace or stretching cast wear, but again, needs some assistance. We cannot independently improve function, and we cannot expect it to last forever. This is in one of these three areas is where I see a lot of the folks that I talk to who say, oh, we tried that once and it didn't work. Oh, why didn't it work? Well, it wore off and we had to do it again. Yeah, that's how it works. It wasn't well explained clearly, and so the family ended up disappointed. It didn't work because the knees didn't straighten all the way out. Well, that's because your child has had their knees bent for the last 15 years and you have a contracture. And I think this is particularly going to be for the therapists in the room, but I think we as practitioners contribute to that some because we have a habit of just talking about muscle stiffness and not distinguishing always in our casual conversations between contracture and spasticity. Oh, the muscle is stiff, the muscle is tight. We don't always do a good job distinguishing that, and so we contribute to this confusion. I'll make sure before I do botulinum toxin injections on anybody that I say, do you know what spasticity is versus what a contracture is? Because I can only even say I'm going to try to fix one of those. Then next, a little slide of some of the common upper extremity postures that we might see in people that we're treating, and muscles in the upper extremity you could inject, which, if you look at the slides, pretty much all of them. And the lower extremity, this is a more limited diagram. It shows the muscles that are officially approved in pediatrics for botulinum toxin A use. Does that mean that's all we inject? No, it doesn't mean that's all we inject. We'll take a look at the patient and say what muscles are causing trouble and treat those muscles. Very often, in addition to these, hamstrings and hip adductors are causing a lot of trouble. Next indication is in brachial plexus palsy, particularly birth brachial plexus palsy. Their indications for treatment are a limited range of motion, usually at the shoulder or elbow. There are not a lot. The studies on this are still not a lot, but showing that it may be effective. In this case, what you're using it on is actually a normal muscle. If you think about the imbalances, say at the shoulder with somebody with a brachial plexus palsy causing an internal rotation contracture, you may inject the internal rotators so that you can stretch them, so that that weaker external rotator maybe has a chance to win for a minute, and the kid learns how to trigger it, learns how to use it. Studies thus far suggest that the risk of adverse events is low, that active and passive range of motion is improved, and different studies have said different things about length. Some only showed improvement for the 3-month duration you can expect from the toxin. Others showed it going on quite some time after that. Next thing we can use it for is congenital muscular torticollis. Congenital muscular torticollis is caused by shortening of the sternocleidomastoid muscle. Trapezius and scalenes may also be involved. It leads to a head tilt to one side and looking to the other, and congenital because it's present from the time of birth. It's often accompanied either initially or after those muscles affect development of the skull and face by skull or facial asymmetries. We're going to take a side trip here for just a second into the fact that physical therapy is the mainstay of treatment for this. And the success rate of physical therapy approaches 100% if you get it started before the age of 4 months. So do not wait for the kid to grow out of it. Do not delay. Get your kid into physical therapy. If you can't get him into physical therapy, get him into my office, and we'll see what we can do. But really don't wait for me, because who knows when my next appointment is. And that's actually the most important point of the torticollis part of this talk. There have been other studies about do we do PT or do we do a home exercise program for torticollis, and there have been one study showed that PT 3 times weekly led to much faster resolution of torticollis than stretching at home. And what's interesting about that is these kids were supposed to only do their PT 3 times weekly. The parents were supposed to not do anything the rest of the time. On the other hand, we know both from this study and from other studies where the family just was told, do your home exercise program. If you have a question, call up your PT. They'll talk you through what to do. That home exercise program applied well and consistently can resolve this. But applied well and consistently, I think, is where a lot of families fall down if you don't have a physical therapist involved. When do we use botulinum toxin? When conservative management has been tried unsuccessfully. So physical therapy, home stretching program, and sometimes you'll bring in an orthosis. The lightest weight, when I meant to get a picture in here, sorry, is just called a TOT collar, T-O-T collar. And it's if you've ever seen that clear aquarium tubing, it's 2 pieces of clear aquarium tubing with posts in between. And you put tall posts on the short side of the neck and short posts on the long side of the neck. Real lightweight, generally really well tolerated because it's lightweight and fairly cool with just minimal structure to it. If you've been working on conservative therapy for 3 months without adequate results, is when you start considering use of botulinum toxin. And botulinum toxin, like I said a minute ago, is not probably going to fix this by itself. You still need your therapy afterwards. Moving from that to the other neck problem is cervical dystonia, distinguished from torticollis, the congenital muscular torticollis, as being a dystonia in which the position is not fixed. Any dystonia is a movement disorder characterized by twisting motions or fixed postures, but they do come and go, caused by involuntary muscle contractions. You can have it anywhere, and it can be painful. I pull out cervical dystonia from the rest of the upper and lower extremity injections because there are a couple special things to talk about injecting botulinum toxin into the neck. And that is that, we said earlier, the proximity of the muscles you're injecting once you get up to working in the neck to the muscles of swallowing raise the risk of dysphagia with injections. You need to make sure you have an injector who's going to use some sort of guidance other than just like, well, I think the sternocleidomastoid should be about there between the mastoid and the sternum. Use EMG, use ultrasound, use electric stimulation, something, so that you know that you're getting into the muscles you need, not other muscles, and not stabbing any of the other important structures in the neck, such as, the carotid artery. In cervical dystonia, most commonly involved muscles are the splenius capitis, semispinalis, and the sternocleidomastoid. But just like as in treating spasticity, look at the person and see what direction they're going and treat the muscles that take you that direction. Moving on, staying in the head for a minute, the emerging use in migraine, which in a way does, I think, come back to musculoskeletal because we're injecting it into the muscles and treating the migraines that way. It has been approved for adults for quite a while, and there is, if you look particularly at like the botulinum toxin website, they have a whole recipe: inject 10 units here and 10 units there and 10 units there and 10 and with the picture of the head, exactly where to put it. There have been 2 randomized controlled trials for migraine in pediatrics, both of them since 2020. So this is very clearly still very new. They've gotten different results. One showed that the botulinum toxin was not superior to placebo, and the other showed that it was. Now, both studies had some issues. The non-superiority one differed from the adult treatment recommendations in that one treatment group got half the recommended dose, and the study was powered to detect a change in migraine frequency twice that of what was considered successful in adults. So for it to be considered successful in pediatrics in this trial, the kids had to have way more reduction in their migraine than the adults had gotten in the adult studies. Not entirely surprising that they didn't see that. But the other study that showed efficacy also had some issues. It was 15 patients, and 2 of them later went on to get diagnosed with idiopathic intracranial hypertension, so they didn't truly have true migraine to begin with. More to come, I hope. Then, lastly is sialorrhea, or drooling. This is a vexing problem for a lot of people. It causes perioral skin irritation, aspiration, respiratory difficulties, articulation difficulties, social stigma. But actually what I hear a lot of is, I just have to change their clothes so much. We go through like 10 bibs a day, and then we change shirts 3 times, and I can't keep up. I don't hear perioral skin irritation here in California nearly as much as I heard it in Minnesota and South Dakota in the winter. The weather is better. Which glands do you inject? You inject the submandibular glands because they're most active in saliva production at baseline, and the parotid glands because they're most active with stimulation. Risks include the same as always, but also chewing difficulties. What's next to the parotid glands? The masseter. Dry mouth because we're getting rid of saliva, and injury to the facial nerve because, again, that's right kind of there. What I think that I'm going to mention quickly, though I did not write it into this talk, is some of the additional studies that have been done on repeated use of botulinum toxin. It used to be that you gave it every 3 months and you didn't worry about it. It was great. It helped kids. It was perfect. It was wonderful. The longer, then it became clear that muscles that were repeatedly injected did suffer from muscle atrophy. That shouldn't be surprising because you're making the muscle weak. It can't exercise in the same way. And as it became possible to get biopsies of some of these routinely injected muscles, there's also a change in muscle composition with decrease in muscle fibers, increase in fatty atrophy and ground substance. Some of these biopsies have come courtesy of the orthopedic surgeon, have come courtesy of generous parents of patients undergoing orthopedic surgery where the surgeon says, do you mind if I just take a little bit of the muscle I'm cutting for science? So it's, for the most part, they haven't been just biopsies for the sake of biopsy. So I think now more carefully about how often these injections are needed, about what the end goals are and what our alternatives are. Where it used to be, oh, well, we'll just inject this person every 3 months forever. I even sometimes that got old. Now I think more about some of the other things like Dr. No talked about, the baclofen pump, the rhizotomy, which can be used just to decrease tone in the low GMFCS folks, even without thinking about how it's going to improve function. It can be used just for quality of life and ease of cares. And that also is work that is still ongoing to see exactly where it is going to end up. And that, I think, is where I will wrap up.